Okay, so I'm going to start with hematomas. And so basically, talk about some hematomas. We're going to start with the ones they're going to see mostly in children, and then talk about some you might see in adults as well. Just some high stuff, how to diagnose them, recognize the hematomas, as well as maybe complications and basic science implications, right, to know about them. So if we look at this, the skull. So the skull basically, the skull is the cavarium itself, the bone, but superficial to the skull, we have the scalp, and the scalp is made up of, right, so the scalp is made up of skin, subcutaneous tissue, we have the aponeurosis of Galen, loose areolar connective tissue, periosteum of the scalarium, right? So basically from the word scalp, SCALP, you can kind of predict the layers of the scalp. So skin, below that subcutaneous tissue, aponeurosis of Galen, loose areolar connective tissue, then we have the periosteum, which is covering the calvarium, and then we have the calvarium, the bone itself. Then we have another periosteal layer, right, on the inside of the bone. And then that's when I get to the meninges, which would be the dura, arachnoid, pier, and then we have the brain itself, the cortex. So some of the spaces between these layers are potential spaces, right, that blood can accumulate in, yeah, and lead to certain types of hematomas. So the most superficial, so first of all, we can see like caput succedaneum, right? There is a condition called caput succedaneum. This is basically like a bruise, right? Subcutaneous bruise. So we're gonna see these um, in newborn babies who probably have some sort of trauma, right, on the vertex of their skull, maybe due to repeated, friction with the pelvic bone or something like that. So after the delivery, you're gonna see like a bruise or swelling basically of the skin. It's gonna be very, very tender. This is super superficial. It's the most superficial hematoma we might see. It's blood in the subcutaneous tissue. The skin there will be swollen. The overlying skin will be swollen, and edematos and very, very tender, right, to palpation. So this is usually present from birth, basically, and it can be anywhere, right? It can cross the suture lines. It is soft and tender to palpation, and you're going to see overlying skin, right? Discoloration as well in this case. A much deeper hematoma will be subgaleal hemorrhage. So blood can accumulate in the subgaleal space, as the space between the aponeurosis of Galen and the loose areolar connective tissue. Yeah. So this one's typically seen in neonates. It can be related to what rupture of hemispheric veins, right? That drains the scalp. However, this is going to be usually present shortly after birth as well. It can expand over time, but the major difference, it can also cross the suture lines. The major difference between caput succedaneum and subgaleal hemorrhage is that what caput succedaneum is, you won't see overlying skin discoloration because it's much deeper than caput succedaneum, right? So the skin looks normal. All you're gonna see will be just a lot of swelling, right, over the scalp. It's gonna be fluctuant to palpation, like soft, usually non-tender, right, and it's gonna cross suture lines for sure. It can be over the parietal bone, the frontal bone, etc., right, coronal bone, because it can cross suture lines. But the skin, overlying skin, will look normal. There's no skin discoloration, no skin swelling, nothing, because it is much deeper compared to, yeah, caput succedaneum. Then if we go deeper, we get to the subperiosteal space. So if blood accumulates between the periosteum and the calvarium, that's going to be what cephalohematoma. So blood accumulating between the periosteum and the skull calvarium, that will be cephalohematoma. So this is also usually seen also in neonates shortly after birth. So since this is between the periosteum and the calvarium, right? Periosteum doesn't cross suture lines, right? So the hematoma will be confined to one cranial bone. You're going to see the hematoma or the swelling over maybe just the coronal bone or over the frontal bone or the parietal bone and stuff like that. But it won't cross the middle or cross the suture lines and involve multiple right cranial bones. And then it's also going to be so unlike the other one, right? So major difference from the other one, first of all, doesn't cross suture lines. It is firm. It's much firmer, right? Because it's actually confined swelling under tension. So it's going to be very, very firm compared to the other ones, which are going to be soft to the touch. And there will be no skin exposure either because it's much deeper, much deeper. So quick recap, Caput is then just a bruise. Overlying skin will be discolored, it's going to be tender to the touch, soft to the touch, it's going to cross suture lines present shortly after birth. Subgaleal hemorrhage, it also crosses suture lines, but also soft to the touch, but non-tender as well, typically. And the skin looks normal. Cephalohematoma doesn't cross suture lines. It's going to be confined over just one particular bone, won't cross suture lines. It is firm to the touch and non-tender, and the skin also looks intact. Right, overlying skin looks intact. In the problem with cephalohematoma, the risk factors of cephalohematoma will be like vacuum assisted, right, or forceps assisted delivery. So if the delivery of the baby was assisted by using like a vacuum suction or forceps to get the baby out, that can lead to trauma to some of the vessels there and lead to cephalohematoma. The concern with cephalohematoma is hyperbilirubinemia because blood accumulates, this is basically blood, red blood cells accumulating in the space. If macrophages get in there and they are eating up, right, the red blood cells, they're going to be degrading those red blood cells in the hematoma. What happens to hemoglobin? They're going to break down hemoglobin and eventually break down heme to bilirubin, direct bilirubin. So this is a major risk factor for direct hyperbilirubinemia in the baby, and we know indirect unconjugated hyperbilirubinemia, which can cross the blood-brain barrier, enter the brain and damage, right, the neurons there, and eventually lead to connectors, right? So that is the concern with cephalohematoma. It can lead to unconjugated, right, hyperbilirubinemia. So which can lead to connectors eventually if it's untreated. So that is a major concern. So those are extracranial, right? Basically hemorrhage. Hemorrhage or hematomas superficial to the skull, to the calvarium. But we can also have intracranial hemorrhage, right? So there are also potential spaces, right, between the calvarium and the dura, which will be epidural space, between the dura and subarachnoid, which will be between arachnoid to be subdural space, in between arachnoid and pia, subarachnoid space. So blood can accumulate within these spaces, and we call them epidural, subdural, subarachnoid hemorrhage or hematomas, right, respectively. So of course, for epidural hematoma, it's due to what rupture of the middle meningeal artery. So it's an arterial bleed. The patient will suffer like a trauma, right, to the temple region, and that ethereum, that's where the middle meningeal artery runs anatomically. And middle meningeal artery is a branch of what external, so it's the terminal branch of maxillary artery. Maxillary artery is a branch or one of the branches or terminal branches of the external, right, carotid artery. Yeah. So you can also be asked that anatomic standpoint. But because middle meningeal artery is an arterial bleed, of course, it's going to be super severe. The blood accumulates pretty quickly. This is somebody that suffers a trauma to the head and they lose consciousness initially, but they're going to gain consciousness and they're going to be talking, walking around, etc. initially until the hematoma gets big enough that it's compressing the brain and it's going to herniation, and then they lose consciousness again, right? So we call that period of lucid interval. Yeah. And then on CT MRI, you're going to see convex shade, right? Hematoma in the epidural space, epidural hematoma. This can lead like uncal herniation if we don't treat it, where the brainstem and the uncus of the temporal lobe herniate through the foramen magnum, and they're going to compress like the midbrain, compress cranial F3. The patient might have like fixed dilated pupil, right, on one side of their unilateral fixed dilated pupil. They may also have upper motor neuron deficit, right, the opposite side of the body, things like that. So that is impending, right, on collineation due to the hematoma. The blood accumulates between the dura and the subarachnoid and the arachnoid space, arachnoid matter, which is the subdural space. That is going to be subdural hematoma. Subdural hematoma is what is it a rupture of cortical bridging veins? Cortical bridging veins. So veins that drain the cerebral cortex. Right, if they rupture, that is going to lead to subdural hematoma. Subdural hematoma can be acute or chronic, depending on the cause. If a patient has subdural hematoma after trauma, yeah, subdural hematoma can be acute due to trauma, right? And some people can also have non-traumatic subdural hematoma as well, like somebody taking anticoagulants, right? Yes, they may develop subdural hematoma. Those veins can bleed easily. Older patient on warfarin and stuff. Patient after a severe motor vehicle accident, they may present with acute subdural hematoma. Yeah. Patients with dementia, yeah, they can present with chronic subdural hematoma, or older patients after a fall. They might present with chronic subdural hematoma, where they suffer a fall because the brain has undergone atrophy, right? There is more movement in the cranial cavity, right? The brain can move backwards and forwards in the cranial cavity more than it would have in younger patients. So the cortical bridging veins can get ruptured easily, right? Yeah, after that kind of trauma to the brain. So patient has suffers a fall in the shower, for instance, and then they are okay, right, for a while. And then over the next few months, start getting worse, start becoming forgetful, organoid deficit, things like that, because the bleed will be slowly building up. Bleed is slowly initial because the venous bleed, right? It's going to bleed slowly, gonna stop, and then eventually it's gonna be drawing water chronically, right? And the hematoma gets bigger and bigger and bigger. Yeah, and the patient start getting progressively worse over a couple of months. That'll be like a chronic subdural hematoma. Yeah. But common in elderly people, especially people with dementia, we can see it in patients with abusive head trauma. So shaking baby syndrome, a baby that is shaking, also about some traumatic head injury from abuse and stuff. Yeah, we can see subdural hematoma together with retinal hemorrhage as well. Trauma can do this. Patients with on anticoagulants might have spontaneous non-traumatic, right, subdural hematoma. But you suspect this patient has, right, headache, vomiting, papilledema, and we check in MRI or CT, we see what crescent-shaped hemorrhage. If the mass is white, which is acute blood, it's an acute hematoma. If the mass is crescent-shaped mass is in the subdural space is dark, which suggests chronic bleed. It's a chronic subdural hematoma here in that case. But if you don't treat this as well, this can lead to what can lead to um, this can lead to herniation as well, which will be bad. Bleeding the subarachnoid space, that would be subarachnoid hemorrhage. We saw this under hemorrhagic stroke. Yeah, anything that affects the vessels, aneurysm, amyloid angiopathy, congenital AVMs, these things can bleed and the blood will accumulate in the subarachnoid space. So these are people that have what? Worst headache of my life, basically. The worst headache of my life, and they have vomiting, nausea, papilledema, neck stiffness, things like that because of meningeal irritation. Yeah, and you can see this in patients with connective tissue disorders, right? Marfan syndrome, Ehlers-Danlos syndrome, patient with polycystic kidney disease, autosomal dominant PKD, patient with hypertension, right? They can develop subarachnoid, right? Hemorrhage leading to that space. So that we should know. We also know intraparenchymal hemorrhage as well. It's a type of hemorrhagic stroke due to either Charcot aneurysm, amyloid angiopathy, AVMs, yeah, hypertension, things like that. But these are going to be types of hematomas, right? Some are extracranial, superficial to the skull bone, and some are intracranial within the cranial cavity. So diagnosing them is going to be